Dr. Borquez is a fellow with the Division of Global Public Health and the Department of Medicine. She is an infectious disease epidemiologist who conducts modeling studies to better understand HIV transmission in vulnerable populations. She's worked with prison inmates, female sex workers, and her new work is focused on people who inject drugs in Tijuana. Thank you.
Well, thank you very much for inviting me. I've just arrived 3 days ago, so this is work from, previous work that I've been carrying out with collaborators in Peru at the Universidad Cayetano Heredia and with other colleagues at Imperial College London. So I'll be presenting some work investigating the impact and cost effectiveness of HIV prevention interventions among transgender women sex workers in Lima, Peru, using mathematical modeling informed by stakeholder analysis and health system capacity evaluation. So a bit of a ridiculously long title, but I wanted to have it all there because I wanted to make it clear that the modeling component is just part of a much broader study that aims to develop a process to determine the best HIV prevention program for MSM and transgender women in Peru that takes into account acceptability, feasibility, as well as epidemic dynamics and cost effectiveness. So basically the mathematical modeling that I will be presenting now is informed by a stakeholder analysis that investigates perceptions on available and novel prevention intervention methods in Peru among members of the community, health professionals and decision makers, as well as a health system capacity analysis. I will be presenting a sub-study that focuses on transgender women sex workers, and the starting point was a transgender sex worker model in Lima that estimated impact of interventions, and this was part of the sex worker Lancet series that was published a couple of years ago, in case you're interested. I'll briefly introduce you to the model. So it's a deterministic compartmental model that divides the population into 4 main groups: transgender women sex workers who are single, transgender women sex workers in a stable relationship. So those are two in the, on the left, clients and stable partners. And each of these groups is subdivided by sexual roles. So those who are exclusively insertive, exclusively receptive, or versatile. And the distribution within each of these 3 categories depends on reporting. So basically, transgender women having more receptive sex than clients and stable partners. And so the arrows show sexual mixing patterns, and condom use and number of sex acts per partner changes depending on partner type. The model also represents the natural history of HIV infection. So people enter the population as susceptible, and when they acquire infection, they go through acute infection with high transmissibility, and then through latent infection with declining CD4, and so with lower transmissibility during this period, up to the pre-AIDS phase, where transmissibility increases again, and then AIDS. ART is also represented here and mimics ART availability in Peru through time. Reduction in HIV transmission on ART is assumed to be 75%, as opposed to the 96%, although this has been revised to 93, I think, recently, but in HPTN 052, because of strong evidence of lower adherence to treatment among transgender women. Not from Peru, there's pretty much no data on ART patterns in Peru for transgender women, but from data from San Francisco and other settings that have strong data for transgender women. The losses in linkage to care and ART dropout are incorporated in the model, and it assumes that transgender women sex workers, their clients and partners, have the same access and adherence to ART. So this is a simplification, mostly because there is very little data available. The interventions that we are modeling are presented here. So the color coding is going to keep going through the presentation, so might be a bit too much to memorize in a minute, but try to. So A is for higher condom use with clients, B is in yellow for higher condom use with stable partners, E is ART following the new guidelines. So Peru changed their guidelines in December 2014 for people to be treated with a CD4 below 500, so following previous WHO guidelines. C is test and offer, so basically an expansion of the previous intervention where treatment is available for all independently of CD4 count. and finally PrEP. And the description, well, the characteristics of these interventions are shown in the table, and so they are meant to be realistic, and they're based on the stakeholder analysis that we carried out. So we assume that condom use with clients will increase by 15%, and this is a relative increase, so times 1.5 as opposed to plus 15%. And it will take 3 years to reach this increase, and it stays stable thereafter. So the intervention period is assumed to be 10 years, and all of these interventions are aimed at transgender women sex workers only, so not their partners, not their clients. It's a focused kind of program on transgender women. The effectiveness of condoms is 70% based on the most recent systematic literature review. Condom use with clients was assumed to increase by 10% to acknowledge the fact that it's harder to achieve increases in condom use with stable partners. And regarding the ART interventions, again, effectiveness is 75%. And the ART new guidelines intervention achieves a coverage of 65% of HIV positive individuals. At the moment, it's around 25 to 30% coverage. And the test and offer achieves a coverage of 75%. And this takes 5 years to reach the coverage. For the PrEP intervention, we used, again, quite conservative estimates, so an effectiveness of 44% based on the IPREX trial, which is much lower than what has been found recently in the PROUD and the HyperGay trials. But this is because of evidence of lower adherence to PrEP among transgender women in the IPREX-OLE trial. The studies are not powered enough to get data specific on transgender women, but there is some tendency for lower adherence. Well, I could spend, I'm trying to stop this noise, but sorry. Yeah, I could spend a lot more time on the costing component of the study, but just to give you an idea of what we included in the intervention. So for the PrEP intervention, this includes a communication campaign, communication material, and outreach, which is assumed to be done through mobile clinics, because this is a platform that has worked well in Peru so far, although it's kind of, the funding has gone away, so they can't do it as much as they used to. You can see that the cost for the drug and the monitoring comes to $1,630 per year, which is very high, and most of this cost comes from the drug only, which is $120 per month at the moment in Peru. There's negotiations ongoing, and it probably will be much lower, but we're using what's happening at the moment. For the ART interventions, this includes a testing campaign, and again, this is done through mobile clinics. The proportion who know their status at the moment among MSM and trans women in Peru, well, in Lima at least, is around 25%, so it's very, very low. And so there would be a strong need for increasing screening in order to reach a higher coverage of ART. For the condom promotion, this includes a condom campaign, condom distribution, and condom workshops to help trans women better negotiate condom use and better use condoms. So the way the analysis is implemented is that we first model the epidemic at baseline, so with no extra interventions, and look at the number of new infections during that intervention period, which would go from 2016 to 2026. And then we compare it to the number of new infections that would happen if we had the intervention. So for instance, condom or ART coverage or PrEP or test and offer, and all the possible combinations of these 5 interventions. And with the aim to identify the most effective and cost-effective intervention. So these are the main results that I'll present today. So you can see that the graphs show the proportion of infections averted over that 10-year period, and each bar corresponds to a different combination of interventions. And I've put as a reference the UNGAS goal, which is averting 50% of new infection in the next 10 years. And you can see that only a combination of all of these interventions could potentially reach that 50% of new infections averted. I'm showing here the interventions in isolation. You can see that condom use with clients in red is the one that takes us further in terms of when using one single intervention, but that combining condom use and treatment, well, it leads us to around 40% of new infections averted. On the right panel, you're looking at the total intervention costs, again, for each one of these interventions. And here I'm just showing the difference of cost once you include PrEP into the combinations. This, again, is because of the very high cost of Truvada currently. So in blue, you have PrEP in isolation. I'm now showing cost per DALY averted for each intervention, and against 3 cost-effectiveness thresholds. So the WHO choice threshold, which is 1 GDP per capita. You see that against this threshold, all of the interventions are cost-effective, but there's quite a lot of controversy around this threshold. So I'm also showing it against World Bank thresholds. So pretty much all of the interventions are cost-effective against this threshold, except PrEP in isolation and PrEP combined with condom use with partners. And when we look at the very cost-effective threshold for the World Bank, the condom use combined with treatment, as well as condom use with clients in isolation, are either very cost-effective or borderline very cost-effective. And again, PrEP is more cost-effective in combination with other interventions. So in conclusion, implementing test and offer combined with increased condom use with clients among transgender women sex workers would prevent approximately 40% of new infections, and it would be highly cost-effective, but it requires care and information system strengthening, and in particular, a big effort in terms of screening and retaining people in treatment. This would imply an expenditure of $8 million over 10 years. And in terms of PrEP, it would be a viable intervention among transgender women sex workers who do not use condoms, but in combination with other interventions, but prices need to drop. And finally, limitations and next steps. This is just a detail, but I want to say it. Converting infections averted into DALYs assumes that the individuals that did not get infected in that 10-year period don't get infected later on, which is not necessarily true. This can be avoided by directly using model estimates, which I've done as well, but I'm not presenting here. We need to identify a cost-effectiveness threshold that is specific to Peru, so I'm working on that because there is quite a lot of debate around cost-effectiveness thresholds borrowed that are kind of standardized. And finally, there is a very, very strong need to collect information on HIV care continuum that is specific to transgender women. Because at the moment, we're using data from either the general population or MSM transgender women. And as well as quantitative sexual behavior information that complements all of the qualitative information that we've been getting. And thank you very much for listening. I'm sorry for speeding, but a lot to say.
Questions?
Hi, thank you for your presentation. I was wondering, the estimates that you used for your model, are those, you may have mentioned this, but were they transgender women specific?
So in terms of behavior, we have data for transgender women. In terms of ART coverage and adherence, it's either information that's from MSM transgender combined, or information that comes from the Peruvian population as a whole, or even sometimes in terms of adherence, information that comes from other transgender populations elsewhere.
Okay.
So it's a bit weak in terms of the ART information that we have.
Okay, thanks.
Hi, thank you. Just a question on the PrEP cost, because I wanted to make sure I had that correct. It looked like it was it $1,600 per person per year? Mm-hmm. Did I have that wrong?
Yeah.
Okay.
And that's only including the drugs and monitoring, so I'm not including there the outreach and the campaign.
Right. Okay. Yeah, which is dramatically different than obviously what we're dealing with in the United States, and why this is much more cost effective.
How much? I can't remember how much it is in the
$13,000 a year.
Oh, wow.
without insurance. Anyway,
Yeah.
but that's,
Yeah.
I had no idea that
Well,
we were, you know,
I've actually been carrying out other analyses that cost it at $30 per month as opposed to $120 per month, because that's the negotiation they had in Brazil, I think, and they're expecting to get the same deal in Peru with Gilead, but undetermined so far.
let's get that deal here. I like that. Thank you. Thank you.